And we're back. I'm Mabel, Jong. Thanks for watching. You're joining the World Healthcare Congress. We're coming to you live from Washington, D.C., and a very warm welcome to those of you joining us virtually. In our studio is Karen Love, Executive VP and COO of Community Health Choice. Karen, welcome.
Thank you.
And you're based in Houston.
I am.
Tell me a little bit about the work that you're doing at Community Health Choice.
So we are a Medicaid managed care organization, about 20 years old, cover about 300,000 members in the Medicaid and CHIP program in Southeast Texas. We're also in the health insurance marketplace, which has been quite a roller coaster for us since the beginning. And we are preparing, we've never served the age, blind, and disabled population, but we have submitted a bid and expect to be serving that population in January of 2020.
Okay, and why has it been so challenging?
I think outside of Medicare Advantage, you aren't seeing a lot of risk-taking or value-based contracting with providers. They seem comfortable in the Medicare Advantage space, but when you come to talk to them about our 130,000 members who are in the health insurance marketplace or the Medicaid population, much more concerned about churn, people leaving plans. Of course, there's been a lot of tumult in the health insurance marketplace. We're down to 3 plans in Houston, started with 8, and so I think there's just concern about how long will members stay within a given provider system or stay with a given health plan, so that you can see some of the return on investment and long-term prevention efforts.
So what are you doing about that?
So we have implemented, because we serve so many pregnant women, we've implemented a maternity bundled payment program with 2 large providers, where we are including both the mom and the baby in our bundle. True bundle of joy, if you will. Goes from prenatal care all the way to 60 days post-discharge, post-delivery for the mom, and 30 days post-discharge for the baby, and working to look at both quality metrics as well as cost metrics for that population, trying to maybe focus in on something that's a little more manageable instead of taking risk for an entire population, saying let's carve out this little particular piece and let's look at what we can do to improve quality there.
And is this a longer term plan, or are you experimenting with that portion of it?
We're experimenting with that. I'm not sure that bundled payments is the answer to all of our members. Certainly we'd like to get to more of a capitated environment with some of our providers for primary care. A lot of our kids are healthy, working towards capitation with our pediatricians potentially. But for some of these discrete procedural type events like a pregnancy, it's easy to craft a bundle around them.
There is data to show that the capitated programs don't work as well as the bundled programs. So how do you mesh the two then, or justify doing one over the other?
I think we're going to end up with a menu of options for our providers. We have over 10,000 providers in our Medicaid network, 70 different hospitals. No one program is going to fit them all, and so the challenge for us will be to design 3 or 4 or 5, maybe 10 different ways of doing value-based arrangements that we can with providers so that we can meet each provider where they are. We do have a fair number of solo practitioner or 1 or 2 provider practices, OBs, PCPs, and so they're just not in a position to take any kind of risk. So we have to talk with them more about pay for quality metrics, whereas some of our larger multi-specialty physician groups integrated with a hospital system, we can talk capitation with them.
Are you taking part in a panel discussion today or a workshop while you're here?
I just came from one. We talked about value-based contracting with a colleague of mine from BMC in Massachusetts, and the woman who is with the DC district health plans on the managed care side, and we were talking about the need really to meet providers where they are, to give them the information they need to make advances there. As you transition towards that value model, you see providers taking more of the traditional health plan responsibilities, and so while we have traditionally done care management and had a staff that done that, that's much more effective when it's coordinated out of a provider's office, but they need the dollars to fund those kind of positions up front. And so we're trying to figure out how can we provide them with some seed money, if you will, to allow them to move down that path and have folks like navigators or care managers as part of their provider system, bringing behavioral health providers into a primary care setting, those kinds of things.
Right, great. And how are you finding the meeting so far?
I love it. I particularly like the small breakout sessions. They've been informative, but they've also turned into more of conversations with the audience. And I think you always learn so much more when you have an opportunity to interact with folks than when you're just presenting stale information. So that's been a real attractive feature.
All right, Karen Love, thank you so much for your time today.
Great to be here.
And I'm Mabel Jong. Thanks for tuning in. Stay with us.
All right.